Hello, doctor. So we can't wait more, right? We'll start our session today. It's fine, other doctors will join later. Okay, so how are you? Okay, hope you all doing well. Okay, so first, yeah, everyone know how to find the STI guideline, right? You just need to, if someone have no idea, just as example, type the Candida, then STI Australia, okay? Like then you will find the related guideline, okay, like that. So and you have the download option here, print as PDF, then you can get the downloadable version of this and you can highlight and do whatever you want, okay. So use that one. Yeah. Okay, so first of all, let's start from the candidiasis. So what is candidiasis? Here. Okay, one minute. So, yeah, let's begin with the candidiasis. So, what is the causative organism of the candidiasis? So, majority is Candida albicans and rarely other Candida species can cause the candidiasis. It's a fungal infection. So, what are the clinical features? So, we should know how it appears. So, symptoms in the penile symptoms are red rash on genitalis, especially under foreskin, may or may not be itchy. Swelling of foreskin if severe and fissures can be seen. Superficial erosions we can see. I'll show penile candida picture. It here? No, not this one. That's that. Mhm. It's kind of like the same, but not the exact. Give me one minute. Terminate. It's fine. Mm, you can see the candida of the penis. Mm, yeah. Okay. So then, how female vulva and vagina appear during the candida infection? Thick white clump in vaginal discharge, although discharge can appear normal or be absent. Do you remember the cottage cheese like appearance we can see in candida in vulva vagina? Okay, I'll show the AMC's favorite picture. This picture, okay, this picture has repeated in October and November exam as well. Okay, so I got this picture in my exam in November. So please remember this picture. If you want, you can make a screenshot. This is the exact picture they are giving for the vaginal candidiasis. Okay, so please take a screenshot of it. Yeah, I will share it in the group later. Okay, then a genital vulva itch or burning sensation can be seen in this candida in vaginal candida patients, and the superficial dyspareunia and external dysuria, excoriation, erythema, fissures, swelling can be seen. Sometimes, in some presentations, we can't see this cottage cheese like appearance in every cases. Okay, in some cases, the vagina can appear as a red brick vagina, like erythematous vagina, due to the this candida infection. Okay, I'll show. Give me 1 minute. I'll show it. We call it red brick vagina. Not always the typical presentation is the cottage cheese appearance, But in some cases, we can see the red brick vagina. Okay, show a picture. A minute. Okay, I'll show here. Sometimes it can just added it. Okay. Yeah, here sometimes it can appear it as this red brick appearance, like erythematous, itchy. So, vulva vagina in some cases, but most of the cases it's like a cottage cheese. I'll show more pictures. So the pictures like here, the cottage cheese appearance here. You can see this is the actual appearance of this. Remember it as cottage cheese appearance. Then, so the next one is they have mentioned something a special consideration. In November exam, they have asked from here. Okay. Recurrent candidiasis is defined as 4 or more episodes in 12 months period and may occur in nearly 10% of women. It should be confirmed by culture on at least one occasion. So the November recall was they have given that picture and scenario with this picture. Okay, this picture, the AMC's favorite picture. Okay, I have mentioned it earlier, but now we have more members. This is the typical AMC picture they are given in during the exam. Okay, I got this question, and they have given this question and asked given about the recurrent case and ask what we should do to confirm it. So in that case, we have to do the culture swab. What is Yeah, do you remember it, doctor? This picture. Yeah, okay. Yeah, doctor, that's right. So, yeah, you should remember that picture. It's very high. Even in October, one of my friend, not one friend, not so friend did, but one doctor sent me that picture in October as well. So, in that case, we have to confirm it by culture on at least one occasion, okay? We should confirm it. Then, other causes of symptoms must be excluded by genital examination, like dermatitis, lichen sclerosis, herpes simplex, like, okay? Then, consider diabetic mellitus, HIV infection, or other cause of immunosuppression if poorly controlled disease. So, please remember this recurrent case, and when patient is having diabetes and HIV or patient is immunocompromised, they have poorly controlled candidiasis. Okay. Yeah. Then how we should diagnose this patient? We should diagnose this patient by microscopy and culture. We call it MCS. So where we should get this specimen? So high vaginal swab or self collected vaginal swab. So remember this high vaginal swab. Usually they are giving this part, the high vaginal swab. A high vaginal swab, microscopy and culture. Then culture for yeast species differentiate sensitivity and differentiate from the bacterial vaginosis, trichomoniasis. So we can differentiate from this culture. Then penile. So if we are getting the swab from penis, we have to do the microscopy and culture the same. Okay, culture for yeast. Yeah. Then specimen collection we don't need. So usually remember the best one is high vaginal swab. Okay, high vaginal swab, microscopy and culture. Then other investigation, recurrent candidiasis should be confirmed with vaginal swab for microscopy and culture with speciation. So that's the question they have asked in November. Then consider non-albicans species in cases of confirmed recurrent candidiasis and consider PCR testing for herpes only if there are suggestive clinical signs and symptoms. So, how we should manage these candida? Who can tell me the management? Just type your answers in the chat. Who can tell me what is the management? The initial management? Mm-hmm. Okay. So,
For
initial.
uncomplicated case, it's topical azoles.
Mm-hmm.
If not tolerated, then fluconazole. And for
Mm-hmm.
recurrent cases, then topical azoles, but for a longer period, like 14 days, or oral fluconazole for 3 doses, 3 days apart.
Mm-hmm. Yeah. Okay. So, here you should remember in uncomplicated cases. Okay, uncomplicated cases over the first episode like that. We can think as examples the first episode. In that case, the recommended treatment is vaginal azole creams. Example, clotrimazole, 10% vaginal cream, okay, uh, from intravaginally at night as stat dose or 3 to 7 day course. So we can give it as a stat dose or 3 to 7 day course. Okay, vaginal azole creams. Example is clotrimazole 10% vaginal cream or 500 milligram clotrimazole vaginally pessary stat. Okay, so yeah. Then for Valentine's, treat with clotrimazole 1% twice daily until symptoms settle, then for a further week. Okay. Then what is the alternative treatment? Fluconazole 150 milligrams orally stat dose. Okay. Then recurrent cases. What is the treatment for recurrent cases? In recurrent cases, you should remember, okay, in uncomplicated cases, we just start from the topical applications, the topical cream, vaginal cream or Presidy. If it's the first line, so the alternative one is fluconazole or stat dose. The recurrent cases treat each episode with longer course of azole cream rather than stat dose and O. Induction with fluconazole 150 milligram orally for 3 doses 3 days apart followed by maintenance with fluconazole 150 milligram orally weekly for 6 months. So it can be either a trade with longer course of azole cream with fluconazole or just longer course of azole cream. Okay. Then alternative treatment is clotrimazole 10% vaginal cream night for 10 to 14 days. Then 500 milligram vaginal pessary weekly after induction. Then this is the weird point. Okay, I'll show why. The Candida glabrata. So Candida glabrata. Okay, I'll show it from it. Therapeutic guideline. Okay, you will see why. What happened? Okay, I'll show. Here, Candida glabrata. Okay, This is the another species. So in this case, okay, this is from therapeutic guideline. Okay, therapeutic guideline, and here, this question is asked in October. Okay, they have given the after confirming with the culture, they have confirmed Candida glabrata, and they already use a sol cream, not the nystatin or anything, a sol cream. And what is the then after? Uh, okay, the patient present with the Candida symptoms, and she was already used a salt cream and without improving the symptoms. Then they have done the culture, microscopic culture. Then they have confirmed it is Candida glabrata. So in that case, what is the next? What is the first step of management? So in here, STI Australia, they have mentioned boric acid 600 milligram vaginal pessaries. Okay, vaginal pessaries for 14 days, one octave for 14 days, and this is their recommended treatment. In here, the alternative treatment is nystatin cream vaginally for 14 days. I'll show what's the difference. In therapeutic guideline, they have mentioned for this the Candida glabrata. Here we have to use nystatin vaginal cream for 14 days as the first line, and the boric acid as the second line. So in that case, what do you choose? Do you go with nystatin or boric acid? What do you think? What do you think, doctors?
Boric acid.
What about other doctors? Mm-hmm.
I'll go with nystatin.
Mm-hmm. What about other doctors? Type your answers in the chat. We have 18 doctors.
Follow TG.
Yeah. Yeah, that's what I'm telling. So in that case, we have to follow the TG, right? Because TG is the mainstay of guideline for the AMC, right? So in that case, we have to follow the nystatin cream, right?
If
We
we
have,
got both options, we should mark first listed.
yeah, because the therapeutic guideline they have mentioned the nystatin, and sometimes in the question they can give they already use nystatin. Then what we should do? Then we can go with the boric acid. Okay. In I'm telling some scenarios. Okay, to imagine you. Then, if some cases patient is pregnant and having Candida glabrata, in that case, we can't anyway give boric acid, right? In that case, but we can go nystatin. Like these are scenarios. Then you should remember different scenario because boric acid is contraindicated in here. Yeah, avoid using boric acid in pregnancy because it may be teratogenic. Teratogenic. Okay. So, if the patient is pregnant and with Candida glabrata, go with nystatin. If the patient, if the patient's, this is the first episode and patient is already diagnosed with Candida glabrata and patient already used nystatin, then we can go with boric acid. If the patient is having uh, patient is having symptomatic candida and patient is already trying azoles, okay, azoles cream and not resolved by the azoles cream, then after doing the vaginal swab culture they have realized it's glabrata. Then what we should go as the initial one, so first line treatment, in that case we can go with the nystatin. Okay, that's how you should remember different scenario. Then you will easily understand. Because in the recalls are incomplete questions. Sometimes in the exam they will give like more like good stem to think about it. Okay, like that. So in that case, we have to follow the TG, right? Yeah. That's why I want to show this book. Okay, so and treatment advices. Intravaginal and oral assaults have similar efficacy. Okay, intravaginal and oral assaults have similar efficacy. Topical therapy provide quicker symptom relief, but women generally prefer oral therapy. Vulvar treatment alone is inadequate due to the vaginal reservoir. Both sides should be treated. Then, the additional of hydrocortisone 1% cream may be provide symptomatic relief. Then, no evidence that special diet or use probiotics influence recurrence. Recognize the diagnosis. If no response to the therapy, oral assaults cannot used in pregnancy. Okay, I'll show. No hepatic monitoring is required for fluconazole use at above doses. And what are the other immediate management? Avoid local irritants like soap, bath oil, body wash, bubble bath. Like, we should avoid irritants, right? Latex barrier contraceptions. Example, condoms can be damaged by the antifungal vaginal cream or oil-based product. Uh, Postcoital penile hypersensitivity due to vaginal candida colonization is possible and response to the partner treatment hydrocortisone 1 cream may be provide symptomatic relief. Okay, partners do not usually require treatment. So remember this part, okay? In the November exam, they have given some, I can't remember the exact question. They have given something related to this one, like something else to prevent recurrence or something. In the answer options, they have given we should treat the partners. No, we should not treat the partners until unless the partners are symptomatic. Okay, please remember these points. Then, what are the special considerations? In pregnant people, may need longer course of topical treatment, 7 days minimum. Okay, because fluconazole and boric acid are contraindicated. Remember these things. Okay, we can't give oral antifungal for the pregnant patients. We can give uh, topical treatment. And the allergy to principal treatment, we have to try alternative treatment. We have to treat partners in here if the partner is symptomatic. Okay, yeah. Otherwise, we are not treating in candidiasis. Yeah. Okay, so what about tracing? Do we need to contact tracing in candida? Tell me.
No contact tracing required.
Yeah, there's no contact tracing is required. So follow up not indicated for uncomplicated indications, right? Yeah. Retesting not indicated until symptoms fail to resolve or consider alternative diagnosis. And 100% of patients with recurrent candida have had yeast culture and genital examination performed to inform further investigation. Okay, just give me 1 minute. Yeah, sorry for that. We are done with candidiasis, right? So, do you have any other questions for candidiasis? Okay, so we can move to the next question, and we will do mixed e-medicine question for the topics that we are discussing today, right? Okay, so next one is what do you want to discuss? Gonorrhea, syphilis, chlamydia? Type in the chat. What do you want to discuss next? What do you want to discuss, doctor? Okay, let's discuss about syphilis. I know you have a problem with syphilis, right? Because it has so much stages, right? Okay, let's simply discuss about syphilis. It's not hard. You know how to download the PDF, right? Here, print as PDF. Okay, I'm showing it again. Okay, so let's discuss about syphilis. Okay, give me 1 minute. I'll show some pictures. I'll add. So, what is syphilis? So, okay, so overview of syphilis. It is the high prevalence in men who have sex with men and in Aboriginal and Torres Strait Islander communities. Okay, an increasing prevalence in major cities. Recent concern in increased prevalence in the general population, especially in women of reproductive age. So low threshold for testing is required. I can't remember the exact month, but they have asked about the what is the group of people who have high prevalence in syphilis. So these are men who have sex with men are the high prevalence in syphilis. Okay, then so what is the cause? Who is the causative organism? It's a Treponema pallidum, right? It's a Treponema pallidum. Okay. Remember this Treponema pallidum. So how this clinical presentation? Okay. Before that, syphilis has stages, right? So, what are these stages? Tell me, what are these stages? Type in the chat.
Early syphilis, latent phase,
Mm-hmm.
whatever secondary phase, and then tertiary phase.
Mm-hmm. Okay. So, stages are here early infectious syphilis, late latent syphilis, and tertiary or late symptomatic syphilis. Okay. In early infectious syphilis, it includes primary, secondary, and early latent infection. Don't worry, we will discuss. Okay, one by one. Early latent infection. Okay, then in late latent syphilis, asymptomatic infection, and here the early infection acquired within the previous 2 years, and the late latent syphilis, the asymptomatic infection acquired more than 2 years before the diagnosis or when the duration of infection is unknown. Then the tertiary one is with the neurological, cardiovascular, gametes complication. I'll show the pictures, okay? So let's little bit discuss about the primary syphilis, okay? So primary syphilis, what is the most common feature in primary syphilis? It is chancre, right? Chancre. So in primary syphilis, presence of genital and anal or oral ulcers, we call it chancre, that occurs at the site of entry. Please remember, I'll show the Shankray, okay? Here, you can see here. Mm, the image has good pictures. I'm finding okay. Give me 1 minute. I'll add some pictures in that PDF. Yeah. Okay. Here you can see the Shankray appearance. I'll explain how what's the appearance, okay? For now, please remember this the picture. Okay, this is the Shankray picture. How it appear? In here, it is ulcer is mostly relatively painless. This is the painless ulcer. Painless. What is in the chat? Give hand pitch. Yeah. Okay, it's a relative painless with well-defined margin and indurated base. So here you can see well-defined margin, right? And the indurated side. Indurated base. Okay, well-defined margin, indurated base. And this is usually painless. Okay, and in about 30% of cases, there may be multiple ulcers and other atypical presentation. So it is necessary to have a low threshold for testing those at risk. Ulcer may be unnoticed, especially if anal, cervical, or mouth lesion. An incubation period is 10 to 90 days, average 3 weeks. And inguinal lymph nodes are usually enlarged, rubbery, and non-tender. Even if untreated, the ulcer usually spontaneously heal within few weeks. Primary syphilis is highly infectious, so and uh, sexually contact and to the fetus. So, what is in the primary syphilis? Primary syphilis, we can see genital, anal, or oral ulcer. We can call it chancre. And this chancre has the well-defined margin and indurated base. Okay, now you should imagine the picture, indurated base. Okay, the chancre, and this is painless, and most of the cases this can be unnoticed. Okay, unnoticed. Like after the incubation period is actually 3 weeks, and after a few weeks, this chancre can heal spontaneously without any treatments. Okay, without any treatment. So, in that case, this can be unnoticed. But in this situation during the primary syphilis, it's very contagious, right? Very contagious. So, we are done with primary syphilis. Now, what is secondary syphilis? Secondary syphilis, you should remember. Okay, 1 minute. Yeah, I'll show. No, we will do image question, then we will find this. Okay. So, then the secondary syphilis. Secondary syphilis present usually after more than 6 weeks after the infection and is characteristic by systemic signs and symptoms. So secondary syphilis usually after 6 weeks of the initial infection. Then the patient may present with constitutional symptoms such as fever, malaise, headache, and lymphoadenopathy. The skin is involved over 90% of cases, most common with generalized rash. What is this rash called? What we call this rash? What's the name of this rash? Commonly with a generalized rash involving the trunk, but maybe just affect the palms and soles. So what is this rash? You don't know it? No, I'm asking about this rash. It's a copper rash, right? It's a very famous one, copper rash. We call it copper rash. I'll show it. It. Here. This is the copper rash because it's copper color. Here. There's a good picture. Here. This is the copper rash. Okay. It's a copper rash. So, yeah, this is the copper rash. But usually this can see in palms and soles. Palms and soles. Okay. Yeah. And rash can be easily confused with drug eruption, pityriasia rosea, or guttata psoriasis. And there may be also alopecia, mucosal patches in mouth and genitals, and condylomata lata. Do you remember this one? So, what we can see in HPV infection, what is the name of that? What is the HPV?
Condylomata acuminata.
Yeah. Okay, you are correct. It's the condylomata acuminata. In syphilis, we call it condylomata lata. Okay, please don't confuse these two. Okay, I'll show a picture. I'll show two pictures. Give 1 minute. Okay. What is in the chat? Hey, what is this? What is this, doctors? Is this condyloma lata or condyloma acuminata? You have to tell me.
Acuminata.
It's acuminata.
Yeah. So acuminata from HPV, right here. The acuminata is HPV and the condyloma lata is syphilis. Usually we will discuss HPV infection as well. I want to show. Yeah, here. This is the condylomata lata. Okay, so condylomata lata usually present with gray raised papules that sometimes appear on the vulva, near the anus, if any other warm interregional region. Okay, so it's a gray color, but in condylomata acuminata, the HPV warts, it is like flesh color, pinkish color. Okay, how to remember. So, and we discuss about the condyloma lata, alopecia, then mucosal patches and genital patches, and copper rash. And we can see the constitutional symptoms as well: fever, malaise, headache, lymphadenopathy. And here we can see neurological signs of visual changes: tinnitus, deafness, cranial nerve palsies, meningitis maybe indicate early neurosyphilis. Okay, and it require intravenous therapy. It's a complication. Then incubation period is 2 to 24 weeks, average 6 weeks. So previous one, the primary one is 3 weeks and secondary one average 6 weeks. If untreated, symptoms slowly resolve. So if the here, if we untreated, symptoms slowly resolve over the periods of week, but may be reoccur. And if secondary syphilis is highly infectious to sexual contact and feed. So primary and secondary both are highly infectious, right? So you should remember. Then the next stage is what is the next stage? The next stage is the early latent syphilis. Early latent syphilis, it's before 2 years, okay? It's before 2 years, and late latent mean after 2 years. Please remember the early one before 2 years, and late latent mean more than 2 years. It is in the chat. What will be the major difference in symptoms of both? Yeah, doctor, I have to upload so much videos. Please tell me someone what is the good suggest me some app like CapCut or something, because I already tried CapCut. My videos are very long, so I can't crop it. Please help me to find out some good app that I can cut the video and upload it separately. I don't know. There's so much problems. I have the videos, but I can't edit it. That's a problem, doctors. Please help me. I know some doctors have ideas who has good technical knowledge. Please help me. Canva. No, I haven't tried Canva, doctor. I'll try. I'll try today and let you know. Okay, Dr. Mefta. Yeah, if it is not working. Okay, the question was what will be the major difference in symptoms of both? Kima E master. No, doctor. I should. Yeah. Please, please, please send me a private message of these names, doctor. Otherwise, it's very hard to. This is the first time I asked this key master. Okay, so doctor, in the primary syphilis. Okay, listen it again carefully. What's the differences? One doctor has asked. In here, we just only have this oral anal genital ulcer called chancre, and it has the well-defined margin and indurated or firm base, and it is a painless. The main symptom in here is the chancre, and we can see the lymphoadenopathy as well here. The inguinal lymphoadenopathy, we can see rubbery and non-tender inguinal lymphoadenopathy. So usually this phase, the ulcer and lymphoadenopathy only we can see. Okay, and this ulcers and everything is usually unnoticeable, and patient unnoticed, and it can spontaneously heal, but patient still infectious. Then after second stage, after six week after the primary syphilis, it can have this secondary syphilis. In secondary syphilis, you have to write down the constitutional symptoms. We can see fever, malaise, headache, and lymphadenopathy. And other than that, we have the main specific feature, the copper rash. Okay, I have described about it, copper ash. Then we can see the condylomata lata. Okay, condylomata lata, it's a wart-like growth. And then if it neurosyphilis develop, we can see the neurological signs as well. And other than that, we can see the alopecia and mucosal patches in mouth and genitals. Okay, we can see these are the features of this. There are so much difference in primary syphilis and secondary syphilis. Okay, so the third one is early latent syphilis. Early latent syphilis is early. Here is infection in the absence of any symptoms and known to have been acquired within the previous 2 years. In practice, this stage means positive syphilis serology with no symptoms at all. Okay, Here, there's no symptoms, but patient's serology is positive. Okay. Then, if any doubt about the length of infection, treat as late latent disease. Early latent syphilis is potentially highly infectious to sexual and the fetus. So early latent mean less than 2 years, and in this case, the main thing you should remember is patient is what? Asymptomatic, but the serology is positive here, right? Yeah, and patient is highly infectious. What is in the chat? Kind master. Okay, I'll check. Then, then late latent. If you have doubts, please write down stages and simply write down the what is the most important points. The late latents, more than 2 years. Here, the infection for more than 2 years in the absence of any symptoms. After 2 years, people are no longer infectious to sexual partners. Okay, in here, partner no longer infectious to sexual partners. Importantly, however, late latent syphilis is able to transmit during the pregnancy to fetus. In the late latent, more than 2 years, an absence of any symptoms. After 2 years, patients no longer infectious to sexual partners, but still can transmit to the baby right during the pregnancy. Please remember each point. Then tertiary syphilis. So tertiary syphilis. It is the late symptoms and complications may develop months or years later in about 1/3 of cases if not treated. Although this is less common in the sorry antibiotic era. So complications are destructive skin lesions, gumas, and cardiovascular neurological diseases. I will show the gumas. It's a very famous one. Here. 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 So complication, okay? It's a destructive lesion, right? A skin lesion that usually occur in skin and skin, bones, and other tissues as well. Okay, painless, dull, red nodule or plaque. Break down into ulcer with wash leather flow. Okay, remember it can be here, here. It's a very destructive lesion right here. It can be in the skin, in other organs, right? You can see it's a very destructive lesion. This is the complication. Okay, yeah. Then, what are the main complications? The tertiary syphilis also it has a it's also complications. So let's check what other complications. So before that, who can summarize the symptoms and important features from primary, secondary, early latent, late latent, and tertiary syphilis? Who can summarize? You should try, doctors. Okay, no one here, right? It's fine, it's fine. Okay, let's continue the topic. So, the complications early neurosyphilis. Infection involved in the central nervous system then can lead to the visual changes, tinnitus, deafness, cranial nerve palsies, meningitis, and require intravenous treatment. So, congenital syphilis, infection of fetus during the pregnancy, which can cause severe multi-organ disease with high mortality and morbidity in both in utero and neonatal period. Okay. So, how we diagnose syphilis? How we diagnose syphilis. Diagnosis is by combination of serology, PCR of the lesions, history and clinical assessment. If there is a clinical suspicion of primary syphilis but serology is negative, ensure a PCR swab has been done and repeat serology after 2 weeks following pres- presumptive treatment. So please remember this part, okay? It's a very high yield part. Then, syphilis points of care test are available in some areas. You don't need to remember that, okay? Then, 1 minute. So, then, what are the sites that we can take the specimen? We can use the blood and swab of ulcer using PCR. So we can use the blood of patient or swab from the ulcer. So test is blood serology. So we have to check the syphilis antibody. Then we can take the ulcer swab for the PCR. In here, in a very early infection, the NAT test may be positive before seroconversion. That's why if we are suspecting primary syphilis and the serology is negative, in that case we have to do the PCR because the PCR is positive in even in early infection. Okay, so remember these things. And in patient with prior treated syphilis, antibodies detected via CMIA, EIA, and TPP test are usually positive for the live. Usually not they are asking about this, but just remember about the serology and the PCR test. Okay, then reinfection is assessed based on the symptoms and significant rise in RPR titer, then seek specialist suspicion. Yeah. The clinical indicators for testing refer for standard asymptomatic sexually transmitted infection checkup. Yeah. Okay, we'll discuss the most important part. Then special consideration. Positive syphilis result in a child should be urgently discussed with the specialist and the child protective service. Include standards asymptomatic STI checkup if anyone is being tested for HIV. Include not. Yeah. Okay. If we get some question, then we can use it. Okay. Then. The management. Another important part is the management. So, here, early referral or discussion with a specialist is strongly recommended where the clinician is not familiar with the management of syphilis. Okay, so specialist is strongly recommended. Patient being treated for primary and secondary syphilis should have RPR serology repeated on the day treatment is commenced to provide the accurate baseline for monitored treatment response. Here also they have mentioned about here. Yeah, we have discussed. Yeah, here we have to check the 2 weeks after treatment and before the treatment. Okay, for the serology. Anyway, we have to for the diagnosis. Then 1 minute. Let's what is important about the serology. Okay, then patient with neurological syphilis require extended course of intravenous penicillin should be urgently discussed with a specialist. So in that case, we have to refer. So what is the principal treatment option in early syphilis? So early syphilis, what are the early syphilis? Primary, secondary, and early latent. Okay, primary mean uh, we discussed. Then secondary after 6 weeks of the primary. Then early latent mean less than 2 years. In that case, we recommend penicillin. Okay, penicillin. Here we have to give uh, it. I'm checking the therapeutic guideline as well. Okay, from my iPad to check whether these all are same. Mhm. Yeah, same. We have to give 2.4 million units intramuscularly as a stat dose, as a single dose. Okay, then alternative discusses specialist, then late syphilis. And in the therapeutic guideline, doctor, they have mentioned, 1 minute, I'll show. They have mentioned as a second line option. It. Okay, late syphilis. No. Okay. If you have the like last year one, in my notes I have added the previous one. Okay. When I was studying the therapeutic guideline, they have when I was studying this syphilis, I used therapeutic guideline as well. In that case, for the treatment of the early syphilis, they have given benzathine, benzyl penicillin as the first line, and the second line, procaine, benzyl penicillin. But now they removed it, right? That's what therapeutic guideline is changed, right? This is the online one, and I have other in my notes. Okay, I'll show. And that's what I was thinking. So that's what we are telling. Like always use the updated therapeutic guideline. Okay, otherwise you will be lost. Right? Even I was studying this the last year, but it has changed. I'll show it. Okay, I'll show it for like sake of showing. Here you can see right here benzathine, penicillin, or procaine, benzyl penicillin. I got this from my note. Okay, yeah, that's what. So please don't follow it. We have to follow this one. Okay, the new one. Here, benzyl penicillin is long acting, and we have to give a long acting choice of early syphilis without central nervous system or eye or ear involvement. So here the same thing, 2.4 million units intramuscularly as the single dose, as a stat dose. In the mobile, doctor, still you can use that share. Then there's options. Then in that case you can select it as a PDF. Then you can use it. I mean, you can send it. Okay, then let's go back. Then in late syphilis or syphilis of unknown duration, the late latent one, more than 2 years. In that case, in here, STI Australia, they have mentioned benzathine, benzyl. This is the chat. If you still can't find, I can send a screen record. Okay. In here, late syphilis or syphilis of unknown duration, like more than 2 years. Benzathine, penicillin. Here we can give the same 2.4 million units and given as a stat dose. Weekly for 3 weeks. Okay, let's check the therapeutic guideline what they have mentioned. Okay, and they have mentioned something else here. Okay, first let's check the here the early syphilis. This is latent or unknown. So this is for the every 7 days for 3 weeks. We have to give the treatment. And the early syphilis, they have mentioned something. Okay, let's check one by one here. Treatment for early syphilis less than 2 year duration. So we know what's benzathine, benzyl penicillin. Then done. Then and we have to advise the patient to abstain from the sexual contacts for 7 days after treatment start until treatment is completed and symptoms have resolved. Then what they have mentioned, and for the patient who have had non-severe or delayed or severe hypersensitivity to penicillin, oh, the next option is, yeah, in that case, we can give doxycycline. Okay, remember this one. For the penicillin hypersensitivity, we can give doxycycline. And management, early syphilis, contact management. Yeah, here the management of sexual contact of patient with early syphilis. So, early syphilis is infectious to the sexual contacts, we all know. Then early primary syphilis contact partners from past 3 months plus duration of symptoms or 3 months from the last negative test. Okay, then second indication, early secondary syphilis contact partners from at least past 6 months plus duration of symptoms or 6 months from the last native test. So last negative test, or early latent syphilis contact partners from the past 12 months or 12 months from the most recent negative test. So, perform serological testing of the sexual contacts and then presumably treat them with benzathine, benzyl penicillin, the same 2.4 million units intramuscular as the single dose. Okay, please remember. Then here also, here the same treatment, the late one, or the duration is unknown, but we have to give it as the 7 days for 3 weeks, the longer treatment. And here also, if the patient is having hypersensitivity to penicillin, we can give doxy. Yeah. Then treatment of tertiary syphilis. So the tertiary syphilis, how we should treat. In repeat serology on the day of the treatment so that and accurate the peak rapid plasma regain, test titer, and record the enabled monitor of the treatment response. And the patient with central nervous system or eye involvement require treatment with IV benzyl penicillin. And here benzathine benzyl penicillin is long acting and drug choice for the cardiovascular gumatus tertiary syphilis without central nervous system, eye or ear involvement. So we can use benzathine benzyl penicillin 2.4 million units intramuscularly every 7 days for treatment. It's the same, the treatment. Okay. I know it's like we have so much, but you should remember, but just remember the mainstay treatment is benzathine benzyl penicillin. If it is if the patient is having hypersensitivity, go with doxycycline. Okay. Okay, we'll go back to this one because usually not they are like not usually they are asked to diagnose like which type of syphilis or like just ask the treatment. Okay, then treatment advice, special consideration. Okay, we discuss this thing, the sexual partners in there. You should remember 3 months primary, 6 months for secondary syphilis, so 12 months for the early latent syphilis until partners have been tested and treated if necessary. Yeah. Then we have to notify the state or territory health. This is a notifiable disease. So what about special treatment situation? In complicated syphilis, refer pregnant people, treat here. Seek urgent specialist advice. Fetal monitoring may be advisable if more than 20 weeks of pregnancy. Ensure partner is tested and treated. Treat as for non-pregnant according to the stage. Only penicillin has been shown to be the effective, so those allergic should be desensitized and treated with the penicillin. And non-pregnant people with reported allergy to penicillin, non-penicillin regime have the evidence, less evidence than penicillin, but shown to be effective. Yeah, here they have mentioned about the doxycycline, the same thing, doctor. Okay, so say I will send the therapeutic guideline as please check the treatment from that. Then contact tracing, it's a notifiable disease. So we know how 3 months, 6 months, 12 months contact tracing and the treatment should be. You then follow up to confirm the patient and give the treatment. How long they should follow up, they haven't mentioned. Here, review all patients clinically and with repeat PRP test at 3 months, then 6 months, and at 12 months after completing the treatment. Yeah, doctor, yeah, you are correct. Okay. Additional outcome. I'll send the therapeutic guideline one as well. Okay. Then it won't be a problem, right? Okay. I'll share in the chat. Then download it. God, I don't know how to send it. Can't get it from computer. It's fine. Okay, so
I
yeah, doctor. I'll send it anyway. Give me one. Okay. Oh, yeah. Thank you so much, doctor. Thank you. You just shared it. Okay, let's do some e-medicine question for syphilis and okay. I will select. Give me 1 minute. Then you will understand. I know you have so much confusions and everything, but it's not very hard if you are come. Yeah, if you're comfortable with it. If you have make your own notes, it won't be a it. Give me 1 minute. I'll select the question. My God, so much question for syphilis. Syphilis. Okay. And the tertiary syphilis. I'll add some candida question also. Okay. You can take a break, doctor, while I'm selecting the questions. Okay, you can have a break, but not more than 3 minutes. Okay. Okay, so let's do these questions. Sure. Okay, 1 minute. And one more thing in the syphilis doctor. Do you remember we just saw some RPR test, right? RPR test. Actually, it's RPR test. It's a rapid plasma regain. Okay. In that case, we are testing non-treponemal blood test. It detect the antibodies produced in the response to cellular damage. Usually, we are doing that to get an idea about the cellular damage caused by this syphilis causative organism. Okay, so it's like a screening tool for syphilis. Okay, it's like a screening tool for syphilis. Okay, yes, I saw some question in there. We will do it later because it has the title report, like the ratios and everything. Okay. Yeah. It's usually for the screening. Okay, let's do this question. A 23-year-old man present to the GP after noticing a lesion on his penis. He first noticed it about a week ago with a minimal progression in the time. There's no pain or pruritus associated with the lesion. He's sexually active and does not use barrier contraception. In the past 6 months, he has had a sexual intercourse with 3 female partners. He does not take any medication and his medical history is unremarkable. His immunization are up to date. Currently, his vital signs are normal and the patient looked well on the general observation. General examination showed the single, painless, superficial ulcer with indurated borders. Which one of the following is most likely diagnosis? Condyloma acuminata, chancre, herpes simplex virus, trichomonas vaginalis, chancroid. So what do you think? What is it? Yes, if you know the theory, easy, right? Here, painless superficial ulcer with indurated borders, right? Well demarcated margins with indurated borders. Here it's a chancre. Chancre is a painless genital ulcer most commonly formed during the primary stage of syphilis. So the next one is 24-year-old woman present to the GP practice with 3-day history of vaginal itchiness, burning on urination and a change in her vaginal secretion. She has not experienced flank or pelvic pain, fever, change in color or frequency of urination, intermenstrual bleeding, postcoital bleeding, or pain during the intercourse. Her medical history include a recent ear infection treated with amoxicillin. She has no other significant medical history and she has subcutaneous contraceptive implant and is sexually active with one male partner. She reports an allergy to fluconazole but does not take any regular medications. On examination, she appears well with pulse rate 86, blood pressure 120 by 74, respiratory rate 16, SpO2 98, temperature 36.7. Pelvic examination revealed notable discomfort on insertion of the speculum and white non-odorous discharge is seen. Which one of the following is most appropriate? Fluconazole 150 milligram orally once, trimethoprim, clotrimazole 1%. So what is the answer? You can see the screen. Okay, most doctors are going with C. Okay, let's check your answer. Yeah, you are correct, right? Present with the vaginal candidiasis, right? White non-odorous discharge associated with the dysuria, but no increase of urinary frequency. It's a typical candida infection. Clotrimazole 1% vaginal cream applied intravaginally once nightly for 6 nights in the most appropriate treatment. Okay. Then, and what is the risk factor here? Recent antibiotic use is a risk factor for vaginal candidiasis here. And the topical clotrimazole is the first line treatment for uncomplicated vaginal candidiasis. Okay. Okay, no need this one. Okay. It's
Doctor,
Yeah, doctor.
is there a relation between fluconazole and COCP, like any of the enzyme inducing
Fluconazole and what, doctor?
OCPs?
Fluconazole and OCP. I'll check and tell you, okay?
Okay.
Otherwise, I can't tell if I'm not sure, okay?
Okay.
Okay, I'll check and let you know. This question is not related to STI, okay? Okay, this one. A 24-year-old woman present to the GP clinic with 3-day history of painless genital ulcer. She reports unprotected sexual intercourse with new partner 2 weeks ago. She has no significant medical history and take no regular medications except for the combined oral contraceptive pill. On examination, she appears well with vital signs within normal limits. There's a single well circumcised, non tender ulcer with firm based on her labia major. And inguinal lymph nodes are slightly enlarged but non tender. Which one of the following most appropriate to confirm the diagnosis? What do you think? What do you think? What about other doctors? We got D's and E's. So most of doctors are going with D, right? 1, 2, 3, 4. Okay, so I'm going with D. Okay, because it's your answer. Okay, let's check. Good. What is happening to my this thing? Yes, you are correct, right? Patient present with clinical features of high suggestive of primary syphilis, characteristic by painless indurated chancre at the site of inoculation, typically appear in 2 to 3 weeks after the exposure to Treponema pallidum. A presence of non-tender regional lymphadenopathy is also characteristic. Also, PCR with rapid plasma region test is the most appropriate diagnostic approach. PCR testing of ulcer swab has largely replaced the dark field microscopy. So the best thing, even we read in the STR filler, they have mentioned Sometimes in early syphilis, the serology can be negative, right? In that case, the PCR is the best answer, and they have here mentioned the PCR with the RPR test, PCR and the PR test is the best to confirm it. So please remember this one, okay? You have to get the information from the e-medicine. And one doctor have asked about, is this a Whitlow? No, doctor, it's not Whitlow. It's a, yeah, it's a Candida infection, okay, here. You can read it later. Whitlow is not like that. I'll show Whitlow. It's in the, not in the nail here. You can see this is a Whitlow here. Hepatic Whitlow. It's a typical picture here. Okay. Then, okay, we will do something with the picture right there. 28-year-old Aborigine man, a remote community in the Northern Territory, present to the GP clinic with 3-week history of non-itchy rash. He also report fatigue, mild fever, and generalized aches. He has no significant medical history and take no regular medication. He works as bus driver. He reports unprotected sexual intercourse with more than one partner in the past 6 months. On examination, he appears well with pulse rate 82, blood pressure 125/75, respiratory rate 16, SpO2 98, temperature 37.8. There is a copper colored maculopapular rash on his trunk and extremities, including his palms and soles. An image of this rash shown below. There are several painless enlarged lymph nodes in his neck and groin. Condylomata lata is noted around the anus. Which one of the following is most likely the pathogen causing this presentation? What's the pathogen? Very simple question. Treponema pallidum, right? Yeah. Okay. Oh my God, what is happening with this e-medicine? I don't know. Okay. Then, a 24-year-old woman presented to the GP clinic for her first antenatal visit at 8 weeks of gestation, confirmed by ultrasound. She has no significant medical history and take only pregnancy multivitamins. She has no known allergy. On examination, she appears well with vital signs within normal limits. First trimester screening blood test revealed positive rapid plasma region RPR test with a titer 1.32 and positive treponema pallidum particle agglutination test. She has no previous history of positive serology. Which one of the following is most appropriate next step in management? Benzathine benzyl penicillin injection, doxycycline tablet, await confirmatory treponema testing, erythromycin tablet, repeat RPR in 4 weeks. What do you think? What do you think? We got A's. Okay. And what other doctors? Okay, let's check the answer. And this question has something we should learn. Okay, you are correct. Here, patient has tested positive for syphilis during the routine first trimester screening. The high RPR titer and positive TPPA without previous history indicate newly acquired infection. Congenital syphilis can cause severe complications include stillbirth, prematurity, multisystem diseases in newborn. Therefore, prompt treatment essential. Benzathine, benzyl penicillin, Injection, especially benzathine benzyl penicillin 1.8 gram intramuscularly as a single dose, is a treatment of choice for syphilis in pregnancy. It effectively treats the maternal infection and prevent the transmission of the fetus. Yeah. Okay. A 32-year-old man present to the general practice clinic with this 3-week history of malaise and fatigue throughout the day. Over the past week, he has noticed new rashes on his feet and palms and has been experiencing excessive hair loss. He has no significant medical history and does not take any regular medication. There is no history of weight loss, changes in bowel habits, or urinary symptoms. On examination, appear well. Pulse rate 80, blood pressure 130 by 85, respiratory rate is 14, SpO2 98, temperature normal, that not normal, 37.8, bit mild. Cutaneous examination reveal patchy alopecia. There's a non-pruritic maculopapular reddish brown rash on the uh, palmoplantar surface with annular ring of the scale around the lesion. A few lymph nodes in the axillary cervical area are palpable with no tenderness upon palpation. Sorry, rectal examination is unremarkable. Which one of the following most appropriate diagnostic investigation? So type your answers in the chat. Give me 1 minute. What is your answer? We got E's and C's. So most of are going with C, right? Okay, let's check your answer. Mm-hmm. Okay. Is syphilis serology? Okay, let's check why. This patient present with classic feature of secondary syphilis, including generalized malaise, non-tender lymphadenopathy, patchy alopecia, and most importantly, characteristic of maculopapular rash on the palmoplantar surface with the annular ring of scale, the copper rash. Okay, this is in the leg. False. Okay. Yeah. Then syphilis serology is the most appropriate initial diagnostic test. This typically include both non-treponemal test, RPRO, VDRL, and treponemal specific test. Okay. Early diagnosis and treatment with benzathine penicillin is crucial to prevent the progression of tertiary syphilis. Additional sexual transmission infection screening include HIV, hepatitis B, C should be performed. So you all go with C, right? Let's check it's why not. Urine nucleic acid amplification test is used to diagnose gonorrhea and chlamydia. It's urine. While sexual health screening is important in this patient, this infection do not cause the palmoplantar rash in there. Okay. So now you understand, right? They're asking the initial diagnostic one. So you have to remember the syphilis serology. But if the serology is negative, then we have to go with PCR. Then what about the other tests that we discuss about? RPR test and treponemal test. RPR test we use to screen the patient and the monitor the treatment, right? Right?
Even reinfection.
Yeah. we have to monitor and screen, right? Yeah. So in that case, you should know how we, like, what are the investigation we used in here, each one, and what is the initial, what is the diagnostic. If this is positive, if this is negative, then what next, what we should do, how we should monitor this patient, like that. Okay. Yeah. Now you know. So, in okay, then let's do this question because they have mentioned about something about this title. Then we have to get an idea about it, right? Okay, I know it's fine. We will try, okay? You have to try, okay? Something. Then we will discuss it. Wait. Okay, I'll show it again. Here they have mentioned blood specimen will be tested for an initial syphilis specific antibody using the CMIA or EIA. If reactive, the laboratory will perform the supplemented testing that we discussed in the question, TPPA, TPHA, and these things. Okay. Then and the NAR test. Okay, NAR test here they have mentioned. Here, diagnosis by combination of serology, PCR of the lesion, histology, and clinical assessment. There is a overall we diagnose. If there's a clinical suspicious of primary syphilis, but serology negative, in that case, we can do the PCR to ensure the diagnosis, because in even in very early infection, the PCR is negative before the seroconversion. Okay. That's why the PCR we use in the negative cases, right? Here we are doing PCR for what? Ulcer swab, not for urine, right? Here, swab of ulcer. Okay. So please remember, don't confuse with other STIs, okay? You have to remember each and everything, yeah. Okay, so please remember, okay, here we use swab of ulcer, swab from ulcer, not urine. Okay, I know you confused with the chlamydia, right? Not of urine. Okay, it's fine. So let's discuss about this question because this is something we should know. A 58-year-old man present to the GP clinic for review of his syphilis treatment. He was diagnosed with tertiary syphilis 3 months ago after presenting with cognitive decline and personality changes. At that time, his rapid plasma region or RPR titer was 1.32, and he complete a course of intramuscular benzathine penicillin. He has he has no other significant medical history and take no regular medications. On examination, he appears well with vital signs within normal limits. Which one of the following serological test would determine an adequate response to the treatment? So let's try to answer this, then we will find it, okay? Sorry for my voice. Okay, so we got B and C. Mhm. Okay, so what is the Mhm. Okay, most of doctors are going with B. Let's check the answer. It's the C. Okay, let's explain why. The following treatment of syphilis. Sorry, serological monitoring with RPR is essential to confirm the adequate response. Okay, we know that. A fourfold decrease in titer within 12 to 24 months indicate appropriate response to the treatment. Here, that means, 1 minute. Sorry, doctor, give me 1 minute. Sorry for that. Again, my voice has gone, right? And I'm talking, I'm getting some cough. Yeah, still recovering. Okay. Yeah, here. So, this is the adequate. What is happening? Internet connection is not stable. So, okay, I don't know why. Me?
Yes, doctor.
Yeah, I don't know. I got logged out. I don't know why. I think because of some connection problem. Okay. Yeah, so the thing is here, it should be a fourfold, like 2 dilutions decrease in the titer within 12 to 24 months indicate appropriate re- response to the therapy. With the initial titer in this case being 1.32, right? Yeah, it's 1.32. So the answer is titer 1.8 at 18 months. So RPR titer 1.8 at 18 months represent the fourfold decrease for the initial 1.32, which meet the criteria for adequate treatment response. This particularly appropriate in the late syphilis where serological response may take up to 24 months. Okay. So you have to remember, like in early syphilis usually the time frame to response is 6 to 12 months, but in late syphilis it's like a take from 12 months to 24 months. Okay, usually up to 24 months, right? Yeah, and what is mentioned in here, RPR titers should decrease at least fourfold within 6 to 12 months after treatment of syphilis to indicate adequate response, but it may take up to 24 months in late syphilis. Right? Yeah. So why not others? This is why not 1.16? Why not it? Why not it?
It's only half, and it's the
Yeah,
late syphilis.
it's a 1 dilution, right? Here it's in our case it's 32, right? It's a 1 dilution drops only. Like dilution mean the 32, then what is next? 24, then 16 and 8, right? So 4 dilution, like we have to divide this 32 for 4 parts, then we can think about it. Okay, then 32 mean no improvement. That mean the 2, sorry, not 1 dilution, 2 dilution. 24 mean but still 1 dilution, and 12 mean no, right? It's not going with the calculation, right? Yeah, that's the fourfold dilution mean. Okay, please remember. That's what we should remember. So what we have. Yeah. So what are the other interesting cases? You all know, right? They again. What is this? Okay, let's do this question as well. 28-year-old Aboriginal man. So the clinical stem is same, right? Non-itchy rash, fatigue, fever, secondary case, right? Secondary case, and they're asking about which one of the following most appropriate initial investigation. So what is it? What do you think? From these answers. We got B's and 5. Okay. Most of doctors are going with B. Okay. This patient present with classic features of secondary syphilis, including copper rash and everything you know about it. Then Treponema pallidum enzyme immunoassay is a recommended initial screening test for syphilis. It detects the specific antibodies against the Treponema pallidum and has high sensitivity and specificity. Other specific Treponema tests include fluorescent. Yeah, you can read it. Right? Yeah, okay. From these things, the most good one is that. And we have confusion, please do all the syphilis questions. Okay, then you will sort it out because this one is not important. What is asking here? They're asking the diagnosis. We know that. Here, this question is good. A 43-year-old man present to the GP clinic with a 3-week history of painless ulcers on his lower lip, also on lower lip. He is otherwise well. He has a medical history of rheumatoid arthritis, treated with methotrexate and prednisolone. His regular medications are methotrexate, 15 milligram weekly, predni 5 milligram daily, and folic acid. He's a current smoker with 40-pack year history. It's a single unused online dating service occasionally. Examination appear well with vital signs within normal limits. There are well circumcised, firm, non-tender ulcer with raised edge on the lower lip. Which one of the following most appropriate treatment? Topical mupirocin, oral aciclovir, oral valsiclovir, intramuscular benzathine penicillin, excisional biopsy. So what is this? Diagnose it. It's a chancre, right? Yeah, you are correct. It's a chancre, right? The typical presentation of the chancre. Yeah, you are correct. So, yeah. Let's check what we have left. No need. This is not today's topic. Metronide, so 1 minute and 2. You know this question. Let's check what is this. Yeah, we know, doctor. You have done like all the important things. Please do the e-medicine syphilis questions. I know it has some confusions. You should know what are the screening tests. What is the diagnostic test? Okay, when serology negative, next what we should do, and you should know all the stages and what is the treatment, and how like if the patient is having hypersensitivity to penicillin, then what we should do, and how we should trace what is the time duration, how long back we should trace the partners. You should remember everything, okay? And doctor has shared the therapeutic guideline as well, so you can read the treatment from that, because in the STI Australia guideline they haven't mentioned about, no, they have mentioned about doxycycline, but in different place. So, but it's easy to read the therapeutic guideline for the treatment part, right? And please remember these pictures, they are high yield, okay? So today we don't have time to discuss another topic, and I can't discuss one more because of the throat, because of cough. Yeah, so if I can have a time, I will type, right, what is the screening test, what is the initial diagnosis, that thing in the chat at least, then you will understand. Okay, because you should know this test as well. Okay, RPR, the tighter one. And thank you so much, doctors. We will meet tomorrow.
Thank you, doctor.
Yeah, thank you so much. And one doctor has asked about the fluconazole and OCP. I have checked. Uh, there's no there's no good interaction between them. I think you're asking about that that induces and those things, right? They are that doesn't include it. I'll check it and send if we have like in something to change. Okay. Thank you. We will get. You can download it from the online doctor as I showed here. Go to here, this type syphilis STI Australia, then print as a PDF, then you can share it. Okay. Here you can share it. So please remember each and every point. Okay. And add the details from the therapeutic guideline. Use the updated guideline. Okay. I showed you, right? I want to show the difference because in last year I was studying, there was something else with the benzyl penicillin, but now they have removed it. Okay. That's why I want to show you. And thank you so much. We will meet tomorrow and try to finish like other STIs because the February exam is coming soon, right? And February doctors, please send your placement letters. I'll add to the February group. And next week, I'm planning to give some advices and I have some plan for them. So please send your placement letters and then I will add to the group. And in next week onward, I'll I have some plan. Okay, I'll type in I'll send in the February group. So that will be helped. And this one is updated in 2025 August. Okay, yeah. So thank you so much, doctors. We will meet tomorrow. I'll send the schedule and we will try to cover the STI. Okay. Bye bye.
Thank you, doctor. Get well soon.
Thank you so much, doctors. Yeah. Bye bye.